I wanted to introduce our speaker for today. It's the first speaker in this AI for Social Good class. It's the set of seminars that we have. We have Dr. Tavpritesh Sethi, who happens to be at IIIT Delhi, is a faculty there. He has a very interesting career. He is also MBBS doctor and a PhD. So he can truly speak about AI and healthcare, unlike people like us who just don't know enough of medicine, but are just trying to get into that area. So he's an associate professor there. He leads the Center of Excellence in Health, and he has a PhD in computational biology. He is globally recognized in the space of data science for healthcare. He received awards in AMR. He'll talk about some of that today. AI-driven early disease detection from Trinity Challenge, the Vivli AMR Challenge, and MIT Tech Reviews TR35 India, which is a very prestigious set of people to be in. And his work focuses on data-driven clinical decision-making, early ICU warning systems, and multimodal AI tools. He's also a TEDx speaker. He's a fellow at Kavli Foundation and DBT and at the Welcome India Alliance. So over to you, Tavpritesh.
Thank you so much. I'll just share my slides. So I think these the slides should be coming up soon. So I'll basically, as they're coming up, I'll focus on some of the work that we have been doing in the past 4 to 6 years actually, starting with ICUs and then going out into the public health setting. And what our learnings are, obviously this is a very small, I would say, sample of the work that's happening in the AI for healthcare space. There's more questions that we have at the point than answers, but also we have some answers. So at least we have some strategies that we can discuss, and happy to discuss more as we go along in the talk. So feel free to interrupt me at some point and ask questions, because I'm trying to condense a lot of information from last 4 to 6 years in about 40-50 minutes. So feel free to interrupt and ask me questions as we go along. I would be talking about AI-driven health systems preparedness, both in the hospitals as well as in the public health settings. As I said, there are opportunities, but also there are threats and more questions that we have to answer at this point of time. So let's start with the good, right? AI for social good. What good came out of building data-driven systems is in the form of a lot in the form of early warning systems. And again, this is a very small subspace of what you may actually count as AI in healthcare, but my work happens to be in this area, so I'll just keep to this, that in understanding health systems preparedness. If you notice the date on this news piece, which is 25th of January 2020 in Wired, it says an algorithm called Blue Dot by a company called Blue Dot, which is based in Canada, led by a pediatrician data scientist, Kamran Khan. Basically, they had sent out alerts that a new pandemic seems to be coming. And still you can see that we didn't have any name for that virus. We didn't know if it was a coronavirus or a myxovirus or whatever, right? So they were still calling it the Wuhan virus because it originated there. So how they were able to do so, they actually leveraged a lot of unconventional data. Typical epidemiology focuses on surveys and lots of testing on the ground and so on, but these guys were working with data that they were able to mine digitally, flights data, what were people talking about. They didn't use social media data, they claimed that, but I'm sure they had some signals from social media as well. So basically this company does that as a business in terms of building early warning systems, right? And it's not one-off report. They actually did that before in 2016, as you can see, and you can see the last author is Kamran Khan. And that was on anticipating the spread of Zika from Brazil. They also published similar reports for Ebola. So it is not something just like a news story. that came as uh, a glitch and then disappeared. So they are basically doing something worthwhile by using the non-conventional data sources. And that's the opportunity that we have as data scientists, that we can actually triangulate a lot of health, sort of at least at the aggregate level, not the personal level, but at the aggregate level, we can triangulate a lot of information about health systems and threats and what we may be able to do. But to be able to do this, we need these three gaps to be addressed. Data gap. Um, how do we get to these data sets and data sources? Even if they're unconventional, getting flights data is probably not so straightforward. And what data to integrate? So I think that's one of the first challenges that healthcare data scientists actually face. Although healthcare is data rich, but the data quality and all of the questions around um, are we getting the right data, capturing the right data, always are something. So digitalization can have some answers around that, basically to have um health systems that are digitalized, and as opposed to digitization, which means we go back and say, okay, let's actually digitize these paper records and so on. So digital first is coming up more and more in healthcare, but we are typically a slower moving industry in terms of digital adoption. So, but that's coming. I would say that's happening quite fast, especially through programs at the national level as well, like the ABHA and the ABDM, that are currently all digital first. But okay, if we have data, the quality of that data is problem. The next challenge is how do we generate knowledge out of that data, okay, or information out of that data. But another challenge is, do we have people who can generate knowledge from that data? And typically, healthcare is a space where um, it's unlikely that if we don't understand the domain deeply, we will be able to generate new knowledge. It's a very niche domain, very patient, I would say, oriented, and a lot of deep mechanistic understanding goes in there. So the other challenge, obviously, everybody faces. You may also face that. Nipun also pointed out in the beginning that the next hurdle that we face is that to have mechanistic understanding of what disease are we trying to look at, what are the um, processes that have generated that data, what are the clinical processes, what are the clinical workflows, and then what are the biological processes that have generated that data. I think so. So basically, that is something where we need to really define our space and try to collaborate, and then collaborate with clinicians, of course, collaborate with public health specialists, and then basically get to that niche sort of question that you can work with. And then all knowledge cannot be translated into action. Some knowledge is just good to have, but we can't do anything about it, right? And then basically our lab tries to address all these three gaps in data, helping build better data systems. I'll give an example from our work at AIMS, but also generating more value from data is something which I'll also try to demonstrate, which comes in the second part, that how can we come to knowledge uh, from data in a more effective manner. And then, of course, not all knowledge, as I said, can be translated into policy. So these are three typical challenges that we might face. My lab works at these three key areas. One is critical care in the ICU setting, which is typically a very tertiary care setting where you can think about a hospital which is generating a lot of data in the ICUs, but then also there's wards that can be a good source of data for your work. We happen to work in more in the ICU settings. We expanded to a little bit more hospital settings, but for very specific questions like antibiotic resistance, which I'll talk about. Next is public health. Again, I'll speak from the perspective of some health systems challenges like AMR, antimicrobial resistance, antibiotic resistance, and COVID-19. And then, of course, a little bit of genomics work that we also do. So let's start with AMR. Why we think, I mean, we know that pandemic was important, still is ongoing in terms of new viruses and new threats every day we hear about. Now, the new virus that has come in, and the Mpox has been declared as an emergency. So we are constantly bombarded, our health systems are bombarded with new health threats. But one of them has been there for a long time, which is antibiotic resistance. Antibiotic resistance is when uh, the same antibiotics that used to work for a certain infection, maybe bacterial infection, maybe tuberculosis, now those antibiotics stop working for those infections, right? And this is actually everybody says, every clinician, everybody claims that they know that this is a problem. My own family members back in my hometown, they say that yes, 10 years back, we used to give these antibiotics, maybe omicacin in UTI, it used to work, and now we have to add another antibiotic to treat these. So everybody knows that it's a problem, but there's very little evidence that what can be done about it, and there's even more little evidence which gives you what to do in your particular context. I mean, evidence from Geneva may be different, even evidence from India, if I just talk about India as a whole. So we try to generate that kind of evidence, which is more fine grained. And I'll start with this very simple example. Since you're all engineers, we did a very simple model. We have more complicated models that will come later, but this is a very simple model which basically was a phase space model coupled with a multi-level linear regression hierarchical sort of a modeling setup. And this is one of these award-winning innovations in the Vivli challenge because it's explainable, you can understand, and I'll show you how that happens. Okay, so the question is that even if we have data, microbiology labs have this kind of data. Okay, so large hospitals have this kind of data where they know what are the resistance patterns um, at actually the patient level. Even not within patient. If I've repeated tests done for patients, I would have repeated culture sensitivity outputs for the same patient, right? So microbiology labs do this kind of testing all the time. What they typically do is they construct 6 monthly antibiograms. Okay, let's actually pull together all data from, let's say, a hospital X. Okay, and then say how does the antibiotic resistance look like in this hospital. But to be honest with you, that's all you can already see that. First of all, 6 months is too broad a time frame. Secondly, a hospital is too big a context. So we know that antibiotic resistance can vary from one department to the other. If I'm looking at thoracic surgery versus thoracic medicine, these two departments will have different antibiotic patterns because one is surgical, you're dealing with different kind of patients, you're doing some interventions, you're cutting open the patients, you're giving a different kind of antibiotic and so on. Okay, so you need to be more nuanced. What we proposed in this was a data set that was made publicly available by the drug company called Pfizer, and we participated in this challenge, which this data were from 2004 to 2022, I think more than 20 countries. And these publicly available data sets, they had isolate level. Obviously, we don't have patient names, but let's say patient X, sputum, organism was E. coli, sensitive to, let's say, imipenem, but resistant to mucus. This kind of data was made available. More than, I think, 2 lakh isolates were available for. We said we built a very simple model. We said that let's actually build a model that allows time interaction because we have temporal data. So it's hierarchical. First of all, we can look at the world, and then we can look at clusters within the world, which these clusters are naturally at, for our analysis in this case, were countries. But you can imagine that you can build this kind of model or any level of clusters. So you can say within countries there are different regions, within regions can be different states, or is it a question? Okay, so within countries there can be more fine-grained, let's say, in India, for example, health is a state subject, so you can have judicial, administrative boundaries, and then you can have hospitals, multiple hospitals, and then you can have within hospitals, you can have departments. So you can imagine that this is a hierarchical kind of setup, right? Where you could have each hospital is a cluster because AIMS sees a different kind of patient profile than Max or Fortis or some other, right? So each hospital is a cluster because they see a different kind of a profile. Within that, each department sees a different kind of a patient. So we did not have that granulation. We only had country. So, but this can be extended to any level of detail, and that's what we're doing currently for AIMS and Max, working in collaboration with them on a BIRAC funded Grand Challenges India project. But very simple, we said, okay, let's have a term that interacts with country, a term that interacts with time and temporal. We allow some temporal changes to happen with the country, and then we estimate what is the baseline resistance and what is the rate of increase of resistance from this very simple equation. And then, of course, we allow some random errors to also be there. This may be simplistic, but this is one of these multi-level approaches which is easy to interpret, right? And clinicians like it, policymakers like it. So we started here. And then we said, once we have the intercept and we have the slope, and the slope is hierarchical slope. It's not just one slope, it's a slope for the world, it's a slope for every different country, right? And then you can go to any different level. So we can actually say that uh, like amplitude of a pendulum and the velocity of a pendulum, can we construct a phase space? And it can even be a phase lagged phase space. But in this case, a simple phase space where we said, okay, let's look at what is the trajectory of these points. Like pendulum, we know that there's a trajectory, right? Because amplitude and velocity, the rate of change of amplitude, follow a relationship, right? Why are we saying that? Because we know that AMR tends to follow cyclical patterns. Okay, so there's a tendency for seasonal variation. There's also a tendency for older antibiotics to become susceptible, I mean, become more uh, and for older antibiotics can become more useful because now we have stopped using them for 10 years. Maybe they can be brought back and organisms have now forgotten their resistance, right? So, and that was seen something in this plot very clearly. Each dot here is a country, okay? And the crosshairs, green line is the world median of intercept for each time point that we are looking at 2014 to 2022. Red line is the world median for rate of change of resistance. Okay. So the first noticeable thing is that the green line is consistent, and this is a loop. So it just goes back to 2014 after 2022. But between 2014 and 2022, you see a consistently uh, rightward shift of the green line, which is an alarming situation that on the whole, the world baseline level of antimicrobial resistance is increasing. If you want more detail, I can actually quickly go to the web page which hosts this visualization and also shows this in slightly more detail. Okay, so let me go and share that the page. That's called MR Orbit. And for reasons that you can now see why we call it an orbit. Let me share that. I'm having a technical glitch here, not allowing me, but let me see. Not taking me back to the meeting. In the meanwhile, do you have any questions? So I think I've stopped sharing. I'm waiting. It's not taking me back to the meeting somehow.
Sorry, is there an issue?
No. So I'm trying to go back to the window which would allow me to share screen, but that window is not coming up. In the meanwhile, if there's any questions so
Yes,
far.
I think the students have few, and I have a few questions. So I'll also ask the student to at least tell their stream so that you get the context.
Sure. Yeah.
Hello, sir. I'm from Biological Sciences. I have a question. How are you measuring the ground truth resistance? I mean, I couldn't get it.
So this is not a predictive model. So ground truth, basically, we are actually, for example, um, hospital like AIMS would be sending blood cultures or urine culture or pus culture, pus for culture to microbiology, and then they would actually say, okay, this specimen like blood came out to be positive for an organism like E. coli, and then they did a disk diffusion and tested for antibiotics and said that okay, basically this E. coli is resistant to amikacin. So that is a data that we are working with, right? So basically, that is a data that we are actually working with. That's the ground level data that we are working. So you're not trying to predict what will be the resistance. You're estimating what is the trend of resistance. Did I make sense?
Yeah. So, and I also had a couple of other questions. One, because you mentioned the cyclical pattern. So in the equation, when you mentioned time, is it time as it is time, or is it like some sine or cosine, some periodic transformation of that to incorporate this periodic notion of time?
So it was monthly aggregated. So basically, it was month 1, month 2, month 3, month 4, and so on. So it was a discrete time.
Okay.
In this case, it was actually yearly. So because this is yearly data, but for other work with ICMR that I'll show, it was monthly data.
I see. So again, just to follow up on that, so how will it know that the first and the 13th month are likely to have some similarity?
First and 13th month. So yeah, so I'll come to that when I show you the
Sure.
decomposition. So we do a seasonal decomposition
Okay.
analysis before
Yeah,
we decompose and then remove the seasonality before we go into
I
this.
see. And a
Okay.
couple of
So,
other questions.
yeah.
So small questions. So in that equation, how would we incorporate something like interventions, suppose due to COVID-19, like there was a change of drugs, let's say?
Great question. So we currently have not done that. We've not modeled that in. So the first thing was to actually understand if anything changed during that time, COVID-19, if antibiotic use changed. So do we see a pattern in that? Our two papers, because actually it was data from 2020, 2004, 2022. So we did not have a lot of window in doing that. And even for our ICMR analysis, we had a similar situation where we had data from 2014 to 2022. So there wasn't enough time after COVID to really make that conclusion, and we didn't find a pattern. So, but that's a very important question: that how would we incorporate something as an intervention and understand that? So, one approach there could be that we specify that in our models that this was an intervention that happened, and then do a causal analysis. But in this, we have not done that.
Okay, noted. And I think you might touch on this question later also. So if you have that, you can just defer that question for now. So I believe once you've done this study, we may also want to eventually, to get some positive effects, reach out to the doctors and show them that this is the case. This is the way AMR is developing in certain populations, etc. And this is perhaps some suggestive action. So like, will you also talk about that?
Yeah, so exactly. So that's exactly what we are doing with the AIMS and also with Max Hospital. And we are absolutely in we are doing projects which are supported, funded, and along those lines to implement some of these at the hospital level. So
Okay.
I'll show some of that. Absolutely.
Thank you. We don't have any further questions at this point.
Okay, so can you see my webpage now, AMR Orbit?
Yes, we can see the web page.
Okay, so basically this is the scorecards. As you can see, this is a bug, right? So, and let me just stop at 2014. Klebsiella pneumoniae, many of you may be biotechnology students, and you're looking at amikacin. You can look at other antibiotics also. So we are doing escape pathogens plus E. coli. Escape is these Enterococcus staph, Klebsiella, Acinetobacter, Pseudomonas, and then these are I would say the pathogens that we need to be concerned about, right? And then you have these different samples, blood, urine, wound, sputum. Okay, and then if I look at Klebsiella mucosum, you can see that I can look at a country like Argentina and then track. So a couple of things that I would like to say. So we say that this is the good quadrant because you have low baseline resistance intercept and low slope. This is good quadrant. Top right is the bad quadrant. You have high baseline intercept and high rate of increase, right? So the idea is, can we first of all find which countries are moving in this region? Okay. Secondly, which countries are spiraling out into that region, and then which countries are stable or spiraling in. So those are the three kinds of information that we get from this, and then this you can extend this each dot to a department. Which department is spiraling out? Which department is spiraling in? Which department is stable? Or hospital and so on. Okay, so that's exactly what Nipun asked. Is we are working with AIMS on department level and with NACS as well. Again, we keep these data private, so one hospital doesn't see the other. But basically, internal stewardship can be guided by this. So if I go from 2014 to 17, you would observe that some dots move in the region which are here. For example, this particular, right? Then, and the other thing you'll notice is that they are actually moving in a circular, an orbital, and that's reinforcing our earlier hypothesis that there's a seasonality component to it. Okay, so if I just look at Argentina, this is the kind of orbit that it actually follows. Okay, some countries like this one here is France, I think. So if I just hover over France, it should bring that up. Yeah, it is in this, not very visible, but it is in this range here. So this is where my pointer is, right? And this is moving, spiraling in and staying that. Most European countries are actually getting to more stable patterns for Klebsiella mucosum. Okay, there's even countries that actually don't move. That's something very interesting for us. So we do this for a different variety of organisms. So what do we get from this? Is basically a kind of a visual scorecard, and then you also have genomic models, which we built Bayesian networks to understand if this mutation is present and this mutation is present. What can I say about the level of resistance? So this was one of our award-winning innovations in the Vivli challenge. I'll switch back to my slides and then move forward with the genesis of this particular project. So are you able to see my slides back again?
Yes, we can see this.
Okay. So the genesis of this was basically a work that we did with ICMR on data from 21 different hospitals across India from 2017 to 2022. We have two studies, one which is already published in the Lancet Regional Health last year, which focused on bloodstream infections, sepsis. The other is on UTI, urinary tract infections. And we would not call it representative study because it's all data from tertiary care centers, okay, hospital, tertiary care hospitals. Secondly, I think we have regional, ICMR has a huge network of hospitals, but most of these, I mean, they don't go to every small district and city, right? So basically it's overarching, may not be fully representative of national, so we don't call these national representations, but give you some hint. First thing that we find that we see that there is a 0.25% month-on-month increase in imipenem resistance in Klebsiella sepsis. I mean, this is alarming because imipenem is one of these aware drugs where we need in the aware classification. These are one of the reserve category drugs. Don't use it every time. Okay, you reserve it for higher infections and so on. So if something like that starts coming up, then you need to be worried about it. And this is something that we started to see. And then I don't have that slide here, which answers Nipun's question. We actually did a decomposition analysis to first take out the seasonalities and then do a trends analysis for looking at the next level of modeling, but I can share those details. Those are in the paper if you want to. So what we did was basically after, so this in time series analysis, we say that we assess for stationarity time series, right? So we first decompose and then we try to take differences, successive differences in time series. And most of our time series were either stationary at no differencing or at most one or two differencing. Okay, so and then we can ask questions. Once you have stationary time series, you can ask questions that if I have two time series, okay, which leads and which lags? Okay, it's something like it's called Granger's causality analysis, right? So we did exactly that analysis here, and we asked this question in two settings. One is, where is the pressure of resistance coming from? Is it coming from hospitals or is it coming from community? Okay, because we know that for some resistance may be spilling over from hospital use of antibiotics, some resistance may be spilling over from people going to chemists and popping drugs and popping antibiotics, and basically we start ending seeing people which are in hospital, they end up with hospital acquired infections and they are now resistant. Both scenarios are possible. Typical way of doing this would be genomics, which is very expensive. We have to do transmission dynamics. Nobody in the world has been able to scale that up. Okay, and we offer a data driven alternative to say that okay, this is something which routinely hospitals do, and routinely hospitals say that whether this was a hospital acquired infection or was it a community acquired sepsis, right? So at least we know that level of information. That so can we use routine data and data science to get to some level of information about what is driver and what is the passenger? Okay, and we see here that anything that is on the right side of zero tells you that hospital leads. Anything that is on the left side of zero tells you that community leads. Anything above the blue line tells you it is statistically significant. So those are three pieces of information that you want to see. And basically, we saw that in this particular Klebsiella sepsis, hospital acquired resistance led the community acquired resistance by 3 to 4 months. And that's not, I mean, first of all, that's not something very surprising because, first of all, Klebsiella sepsis usually happens in the hospital. So, whatever is happening in the hospitals will be treated first in the hospitals and so on. But this also gives us a handle on what is the kind of spillover pattern. It does actually eventually make its way into community and not too far into time. 3 months is not distant, right? So we do see that kind of a relationship on month uh, change in pattern, which is statistically significant. Second question we asked was, can we have some surrogate markers for reserve category drugs like imipenem? That if this drug resistance comes up, in this case ciprofloxacin, that was 8 months leading the emergence of imipenem resistance. And again, this is important because we know that there's horizontal transfer of genes and so on. So these can give us some early warning signals. Now imagine if this can be done at hospital level at a more fine-grained resolution. They can actually say, oh, my unit or my ICU is seeing this signal if validated for that setting, right? Now, this is an overarching Indian data, right? But we would like to validate it for that setting. Somebody asked a question on ground truth and so on. We make these predictions, validate. So these could actually give you early insights on how can data-driven stewardship can happen. Then we also put these in the context of a Bayesian network where we said, how are these antibiotic patterns um, informative in the context of the development of that state? I mean, we keep talking about sustainable development goals that we need to meet by 2030 or 2025, whatever the target is, milestone is. And then we say that having low infection rate is one of those targets, right? But what about AMR? So for the first time, we believe we showed that there is a coupling between achievement of SDG goals at the state level. That data was pulled out from Niti Aayog's data on SDG. and we combined it with ICMR data, and basically built a joint probabilistic graphical model, and we found surprisingly that there is a couple. SDG3 achievement is linked with independent resistance, and high development means low resistance. That was seen here in this plot, because this is a model. You can actually query this model, and you can see that, okay, if SVG achievement is good, like a state is a front runner state, you see a less independent resistance in that state. Okay, now I'm not saying that this is a causal sort of a thing, but at least it's an association, it's coupled. Okay, and the second thing that we say that they are they're not uncorrelated. So we ask this question a lot many times, that if you have more development, will it lead to more ICUs? Will it lead to more irrational use of antibiotics? Probably, and that is one side pulling the equation. The other side is, if we don't have development, we have more infections, we have more people dying, more spread of infections, right? So which one wins? Our analysis clearly shows that more development is better, not just for sepsis, but this was also seen for UTIs, in that even in a much more clearer fashion. Okay, so in two different infections, we see the same thing come up, which gives us more confidence. And this paper is currently under review. That the development and AMR are tightly linked to each other. Causal, we won't say, but we need to address this issue. So Nipun had said, what do we do with this? We actually deploy these as dashboards, and this is one of our Grand Challenges India project, which we are implementing both with AIMS and MAX, where we have implemented these antibiograms. So with AIMS, you can see that this is hospital level. You can choose which department or unit. You can choose what what sample, and what organism do I want to look at. And then you can choose what is the antibiogram that is coming up. And then we are building the MR orbit validation on top of what we're seeing this, because we have retrospective data from these two sites. So I think these two innovations, I'll take a pause after this and take some questions. So this was one of these innovation awards in 2024 recently. And the other big win for us was the Trinity Challenge, which is a global challenge in like Bill and Melinda Gates grant challenges. So this comes out every 3 years, and we were the joint second prize winners, which is a 600,000 pounds prize, about 6 crore of money to implement this for community level. We're doing this in collaboration with Tata 1mg and PATH and ICMR as a part of it, because what we have is hospital level, but how can we extend these kind of scorecards to beyond hospital and include community? And that's what I will come to in a little bit. So I think there was a question, and I can take any questions if you have. Was there a question? I heard a.
No, I don't think. Okay, there's one announcement produced.
So I'll go forward then.
No, sorry, there is one question.
Hello,
Yeah.
I am PhD computer science. So I have this very interesting question. So for the AMR orbit, you sort of have this very good orbital graph analysis. I'm not sure what to call it. But this is based on the country, right? So my question was, do you have the data on ethnicity as well? Do you think it would be interesting to see how ethnicities move instead of countries?
You can bring in any level of detail. If you have that kind of data and you have a hypothesis, you can actually, I don't know if ethnicity, but I'm sure even multiple ethnicities within the same region having the same level of development. For example, in one of our earlier papers, we showed that access to maternal health was one of these important features, especially for low-income countries. And we did a causal counterfactual model on that to say that, yeah, if we do that in low-income countries, this is the impact we get. But if we do that for high income, not much impact. So if you have a hypothesis on ethnicity, maybe some ethnicities have some genomic variations which make them more, I would say, susceptible to infections or maybe even more responsive to some antibiotics, you can go to that level of detail as well. And include that as a level in your multi-level model. The challenge is that, of course, you need to have enough data for each of these. The more lenses we create and we create stratification, you'll need a lot of data also to go. But good question. So
I had one very naive question, perhaps a very selfish question. Should we be worried sitting in India in, let's say, urban cities about it?
Absolutely. I think it is absolutely a point of, I think previously we also knew that it was a problem. But I think with the pandemic, if you actually look at in September last year, there was a UN General Assembly, and there were 3 high-level meetings just around AMR, countries talking to each other that this is a major problem. I don't know what happens now with WHO situation with the Trump and all of that, but our data shows it's a clear problem, not just at the country level, but at the world level. And not just our data, actually, every week now we are seeing more and more alarming reports coming out that WHO has said that by 2050, I mean, we initially thought it's like creating more. By 2050, 1 million people will start dying every year because of simple cuts and bruises and wounds because they will not have antibiotics to treat simple infections. It may not be that number because this year, good news is we also had these Nobel Prizes in AlphaFold. So hopefully we'll jack up the pace of antibiotic discovery. But basically, if we stay on the same trajectory, we are definitely in a. So it's not just our work. We also need to develop new antibiotics. But to be honest, I think the most important thing that we miss is infection prevention and control, IPC. We cannot, every drug that we have to test, although it's the most attractive space, takes about 13 years to come out. COVID vaccine was a different story. But 13 years is the average time for initialization to actually first market hit of a drug. And AI may shorten that period by some amount. Maybe it will become 10 years, 8 years, but still, drug discovery is not the only way to go. So we'll have to actually put together some policies, some infection control practices, some antibiotic usage policies. I think that's where some of our work is also trying to advocate for. But we are definitely in a situation where we need to be worried about it, and hopefully more people will join in, more students, more colleagues researching this together, and the more we actually are able to understand this, I think it's a better space to be. Shall I move forward?
Sure, please.
So we are doing this in the AMR Sense project for Trinity. We are using AI, state of the art, trying to build in a longitudinal sort of picture of we now are in a slightly, I mean, with the new data protection law act that will become a law, the minimum fine for any personal information is 50 crores. Even if we don't do that, if somebody raises a question, I think so. We are still revisiting. Should we actually go to individual? Aggregated data is what we are currently thinking about. But we have a strategy around individual prescriptions, aggregated, working with LLMs and OCRs around those, and then basically building models. And this is the slide that I was missing earlier. So you see that these are in our previous. There's a seasonality component, there's a trends component, and there's a random component. So when we said 0.25 month-on-month increase, that was coming after the decomposition into seasonality and trend and random, and then looking at what is a trend of rate of increase of resistance in that particular drug bacteria. And then, of course, this is a proposal that we have said in Trinity. We'll be doing this in one of these states in partnership with CHRI Path, ICMR, and 1MG. We are triangulating consumption, antibody consumption data. Imperfect because not everybody goes on 1mg platform to buy antibiotics. Most of people go to chemists, but that's why we call it AMR sense and AMR aura. It's not a perfect representation. We're trying to see how much we can track. I mean, so a lot of this is actually around building social incentives, badges, being an MR ambassador who can then ASHA workers, for example, redeeming some of these badges for health checkups or whatever, right? We can't incentivize them for with money, but at least we can build some motivation with these badges. Recently, we also launched we launched a game called Infection Escape, which basically is like a temple run game, but allows us to understand what is the level of awareness. And it's in 2 languages right now. We have not formally launched it, but I'll just show you a demo. I'll just, I mean, use these 2 examples. One running into washing hands, the other is running into, and there's many more scenarios that we're building with ICMR and validating it with other. So it's a very early stage, but we are looking at validating some of these and pre-post learnings, targeting ASHA workers as of now, because we are not going to, I mean, we can go to people, but also understanding this at the slightly. So again, this is an opportunity where we can build collaborations. A lot of serious gaming is coming in, and we have to figure out what the incentives are. But at least I think the social badges is something that we are actually looking at and building leaderboards. So I'll skip this part. We did something with primary healthcare settings in Madhya Pradesh, Bhopal, where we found, as Nipun asked, do we need to be concerned about? Yes, there we saw at a primary care setting, that there was this very infamous triad of a drug which reduces fever, drug that treats infection, and drug that treats allergy, right? I mean, either the person would have allergy or the person would have an infection. But what is happening is that there is this triad that treat for everything. Allergy है तो allergy ठीक हो जाएगी, fever ये infection ठीक हो जाएगी, and the fever को कम करना है, right? This needs to be curbed, right? And then we have these kind of models that we developed for these primary healthcare settings in in Sanjeevani clinics, which are like mohalla clinics in Madhya Pradesh, in collaboration with Wish Foundation, and was actually supported by Gates Foundation and WHO Alliance. Unfortunately, the rollout of this model, because Wish Foundation is now a part of, due to some of their organizational changes, there's nobody taking care of this model now. But I mean, something that we had very early good insights on going forward. That's the other challenge, right? Everything you do as a data scientist, you want government to take up and implement, right? Or an implementation agency to take up, but there's other challenges. Their contracts run out, or they lose trust with the government, and so on. So many different challenges. I think so. These are something that we have learned to actually work with. So the story is that just developing models is not enough. You need to keep advocacy for it. You need to have the right partners. You need to have, and even then it may not work. We had probably the best partners in the country at that time, working on digital primary health, but unfortunately, some issues can always pop up. Okay? So if you ask me a question on ये कौन use कर रहा है, I won't have answers. But we have a framework called Chikitsa Chakra. We have developed it, open sourced it. If you have partnerships, you would like to test it out. We are currently doing this with CDAC to understand the same thing in hospital level. But again, I mean, implementation is a different story. I'll skip some of that. My second part, and I think I'll start getting a little bit faster, is so public health was my first component. Second is ICUs. Over last since 2016, we have models and data sets that we have built at AIMS for ICU settings, in a very niche kind of work, we started small, one small ICU, 8-bedded pediatric ICU. We said, okay, let's actually, ICUs have a lot of data that gets overwritten every day. Can we warehouse these data and then start building models? So these data are like heart rate, pulse rate, oxygen saturation, respiratory rate, every beep that comes on the monitor, every second heart rate is there because doctors come and they look at it every 24 hours, but then it just gets overwritten. So we saw value in actually building an application to warehouse this and to take that data out. It took us a lot of time because it's not easy. Many companies have their own locks around these data. We were able to work around with some of that, and now we have a commercial solution also with Philips. But the idea is we can leverage ICU data. Now we have more than 2 million patient hours of this kind of data. We started very simple, as you can see, working with Raspberry Pis and connecting with monitors and getting some HL7 kind of record and passing it and then going to time series. These are very early days. And then we started with some very simple dashboard building. Now we have models that are actually quite mature, which look at if I have last 24 hours of data, can I predict what is going to, I mean, is this patient going to crash in next 12 hours? Those are kind of predicting prognostication that we have. And you can see these are heart rates, pulse rates, oxygen saturation, and so on. Some of our early works in this was published in 2019, where we looked at computer vision models and were able to predict which baby is going to crash based on domain understanding. That time we did not have a lot of data. Now we have 2 million hours, and even now we don't have a lot of thermal imaging. But we said, okay, can we use the domain understanding that patients' bodies have a gradient of temperature. Center is, and that this is first year medical school physiology knowledge. If center is warm, hands and feet are cold, and patient has a certain heart rate, think shock. Okay, so basically temperature gradients, because if a patient is going into shock, the body moves blood from less important organisms like hands and feet to more important organs like liver, kidney, heart, and so on, right? So basically that's the idea. We built these models which were able to segment out these body parts. At that point of time, we didn't use deep learning, we used simple, and we did not have enough data for deep learning at that time. So we used histograms of oriented gradients, features around those, and then segmentation, automatic segmentation, and then basically building models which are hierarchical models, linear mixed effects models to predict if the patient is going to shock. Long story short, we were able to get to 75% prediction 12 hours ahead of time. Now you may say, is 75% good enough? It's not detection, unlike detecting tuberculosis on a chest X-ray. This is like predicting what's going to happen 12 hours. So, I mean, the general understanding is that in that situation, we don't have a ground truth that how much a doctor is able to predict. And that's ground truth is what we're currently doing now for a study that I'll show you. So with vitals data, we are also able to validate some of the vitals based model, more than 200 ICUs, which are also adult ICUs, cardiac surgical, medical surgical, neurosurgical, and so on. And with more than 90% AU, ROCs, AU, PRCs also are quite good there. And that's what we are able to achieve with time series. Your question would be, are these deep learning models? I mean, this is a response that we get from every reviewer for the last 2 years. We've been trying to say that basically we have tried transformers, we have tried LLMs. Every time something new comes up, we have tried, but we still get comparable accuracies with time series features. Okay, and I'm not saying that just use heart rate average. I'm saying that there's a domain-based time series feature understanding coming from complexity of time series, Fourier transforms, wavelet transforms, and so on. If you take a battery of those, actually still we are out, not outperforming, but performing comparatively at a much less cost than deep learning models. And we've been defending this paper for almost a couple of years now. Hopefully we should see this, but we have dashboards around those. And then, so again, I'll take a pause here. This was our ICU story, and then I'll go to genomics, and then I'll end my talk. I know we are running out of time. So are there questions around this ICU story in general?
So, yeah, so there is one question.
Hello, Professor. It's me, Ayush again. So I want you to know, like, where else have you used the thermal recording? Like, were there any other diseases or any other projects where you could use the thermal imagery?
Great question. So our work here was in shock. You can use it for a variety. People have actually done it for a variety of conditions. We have not used it, primarily because of two reasons. I think there's practical challenges associated with it, right? Although we have a paper that was published, which looked at thermal videos. Okay, first practical challenge: most of the babies are covered. Okay, and we can't uncover them just for our model to work all the time, right? So it was good as an exercise, again, as data science exercise, that yes, there are signals. And we actually, in our paper, I'm not showing the data, we show that um, we automated this process, that you detect when is the child uncovered. Okay, that's a very simple computer vision problem. And then when the child was uncovered, then you calculate the gradient and then you make a prediction. And that paper is published in Frontiers in Physiology. I think was published in 2022. Where we use continuous. So if you're just doing an image, right, the challenge is when to take that image. Who will take that image, right? The next was obviously, okay, let the recording run, and then the baby is covered. So we said, okay, let's go a step further, automate uncover detection. But then is that the best window to say that now we are ahead of, let's say, 4 hours ahead of time? So those kind of practical challenges actually came up in the ICU setup. But there's a whole lot of problems that other people have addressed. Even in breast cancer, there's a startup near my which works exactly on detection of early detection of breast cancer using thermal imaging. There are other areas like drowsiness detection, thermal imaging, and there's other areas also. So we felt that it was too much of a, that's why we switched to these vitals, because second was, it was not something that ICUs routinely do. Thermal imaging was interesting as a modality, novelty, but we wanted to make thermal imaging as the fifth vital. Okay, I mean, we still have to generate enough value to make that statement, but typically all ICUs don't have thermal imaging. Okay, so what can we do with routine data is usually our is question. So I hope I have answered, but there's a whole lot of papers around thermal imaging that you can actually pull out and work with.
Okay. Thanks. So actually, the question also came from some of the work we've been using thermal imagery for sleep apnea detection and with the collaboration with AIM. So we'll connect offline on that with you and we can have some discussion.
Happy to. I mean, so ours was, I would say, it's a problem statement. If I think that if that is something good, the good things about thermal imaging: non-contact, non-invasive, maybe slightly less challenge around privacy of patients. I think those are very good points. So happy to connect.
Sure.
So last is generative genomics. And this is again pre-LLM era. ChatGPT was not launched yet. In the COVID time, we said, can we use small language model? There was BERT and Vertuec at that time that were available to learn embeddings and trying to understand the COVID-19 sequence as a book, because read that as a book and then perhaps understand the grammar and then see how fast is this grammar changing and what can it tell us about the phylogenetic evolution of the virus. So basically, we could ask this question because there was a lot of sequences at that time that were being deposited online. More than 3 million sequences of different countries had deposited. And these were all the countries that we looked at. We trained models. We used cosine similarity to say, okay, what is the distance between this sequence and the next or the other, and then use that distance as a phylogenetic analysis metric to reconstruct. And we were able to actually say that, yes, it captured the phylogenetic evolution of the virus. So the first thing was very interesting that yes, there were some grammar change patterns that were captured in this phylogeny, because we knew that there was a temporal sequence here in this plot, and there was also, I may have that slide, countries that were close together in proximity were also close together in this cosine similarity space. Yeah, so this is 3 million sequences. This is a training validation setup. Actually 2.8 million sequences, and then different time points at which we were able to do this, right? And once we learn the embedding or the latent dimension of the grammar space, we said that are there any dimensions which are giving us a lead time, similar to what we did earlier, what leads, what lags, and we know the number of cases which we pulled out from Johns Hopkins University, and then we know what is the how fast is what is the grammar, because on GISAID you say that what was the date of infection, right? So even though the sequencing may happen 5 months later, but the sample actually says that this sample is from a patient who got infected on this date, right? So we use that as the as the time point, right? So basically, and then we saw that there was indeed a pattern. The red line leads the gray line by almost 2 months. Initially, we thought this may be just a fluke, but then we saw that this was actually true for all these countries: US, India, Germany. The blue line here is the entropy of a certain grammar dimension. Don't have time to go into those details, but you can imagine that the grammar, how fast is this grammar changing, is captured in one of these underlying embeddings. And then you see that there's a cross correlation of that with the cases with a lead time of 2 months. Not every grammar is lead time. Okay, there are other grammar dimensions which have lagging or they are, but this 32 is consistently leading in many. So here you can see that LS32, 2 months ahead of time, there's a lead, which is represented by this. This is 0, this is 2, so 2 or 3, right? So, and then that's also seen in this particular analysis, also validated in this analysis, and we also saw that in the machine learning analysis. And when we go back, what is there on this dimension 32 here? We saw that these are some of these important mutations that we know. This is a mutation that was important for delta. But there's also some others which we did not know. More importantly, delta, there's an important variation in delta saying that will require retrospective analysis of 6 months of data, but we can be more proactive with our models in this scenario as data gets deposited. So that's the hope going forward. Health systems keep doing more genomics, depositing data, public availability of that data, which is a huge challenge. In COVID, everybody became open suddenly and started depositing these sequences. Nobody wanted to die, and I mean, countries to collapse. So now we are back where nobody wants to deposit sequences. Nobody talks about depositing sequences too. And those are the challenges that are beyond our control, right? So, but at that time we had this openness and we could build models which were giving a lead time. Perhaps we were actually one of the few models globally which were able to have a lead time of 2 months. How much was that used? We were a part of the Delhi Science and Technology Cluster, giving this insight to INSACOG and so on. I don't know how much of action happened, but at least we were there. We gave this information. We did our bit. And that this was a dashboard, which we call ScreenFlow, which made this publicly available. I'll skip this. I think this is something that I would like to skip. AI has a bad side phase as well. Most of us know that as the pandemic was evolving, the misinformation was also growing at maybe 10 times faster rate. Okay, and these were some early papers which said that everybody was on a digital platform. We were consuming a lot of information, a lot of misinformation, and that was a much bigger problem than the pandemic itself. People doing wrong things and taking wrong cues and all of that, right? And more recently, if you look at this 2020, not so recent, but 2023 November, there was a paper in JAMA which they used, and that's coming up next, where basically they say that AI now needs to be looked as just like a drug. It has a potential to create a huge challenge of public health I mean, and this is being said by JAMA Internal Medicine. Typically, journals like JAMA, they don't like to talk about these things. Okay, they only publish stories which are this drug did this in this patient, so we should use this in clinic. I mean, this is something that they were able. It's a analysis that they were able to produce and this was published in 2024. Came online, which they were able to generate using generative AI within an hour, 102 blog articles, all made up of disinformation, all fake, related to vaccines and vaping. Okay, so we know this, right? On Twitter, we know more people, more bots than people, and so on, and we all know that. But this is the first time a medical journal and a core medical journal of this stature saying that we need to have AI vigilance, just like pharmacovigilance. Okay, so I think that's the thing about that. So key pillars of pharmacovigilance, including transparency, surveillance, and regulation, need to be applied to AI as well. So all is not hunky dory about AI. There's, as we know, a bad side to it as well, that we can do a lot of harm with the AI. What we did during the pandemic, I'll skip a lot of, I think we are running out of time, but we tried to bunk misinformation with language models themselves. We understood what emotions does misinformation ride on, and how does it affect government policy, or government policy affect emotions in bidirectional manner. This was that paper, early paper in 2020, actually, looking at different states, looking at how governments respond to emotions on social media and vice versa. Then we looked at literature to understand what was the, actually, I'm not showing that literature paper here, but vaccine beliefs. What can we tell about vaccine beliefs, like hesitancy? So we show that we can use social media. Now Twitter doesn't allow this, data to be downloaded. At that time but we could calculate how did vaccine hesitancy changed as an emotion using language models, and in India and the US, and what kind of, but also what emotions does misinformation ride on. Okay, so we had data from CMU, anti-vax, COVID, and we created our own data set saying that, okay, which are misinformation, which are correct information. We characterized emotions in these. Most of these emotions are disgust and joy. Okay, so people tend to be more, I would say, loud in terms of emotions when we express something about health, and that's seen here. But then we have an analysis which showed that much of misinformation in India actually rode upon fear, and much upon in the US actually it rode upon disgust and surprise. And I think it had actually real consequences on vaccine and cases uptake. So that's something that we are still defending in literature, in journals. So I mean, that's carriers of misinformation that we characterize. We also developed an app called Wash Karo, which tried to provide the right information, the right people, the right format, right time, which looked at small language models, summarizing this information from news, summarizing WHO reports, finding what are the best similarity metrics which are validated by a clinical team, providing those as a text-to-speech audio bite. Okay, so all done in an automated fashion, and then delivered and consumed in the form of an app called Wash Karo. And you as a user could give thumbs up or thumbs down, whether that is misinformation or good information, right? Or our model is correctly predicting it or not. So there were about 7,500 plus users within the first 3 months of this app, and then all apps except government apps were taken down as a policy by Google. So we only had 3 months to experiment with it, but those 3 months actually gave us very interesting insights that with more thumbs up and thumbs down, doesn't matter what, our models were getting better and better at prediction of misinformation. That's something which we published in scientific reports. More females engaged with the app in Hindi in general, more males. That's something that we need to solve for. There's lesser number of female users in general. It's a question of inclusion, but also lesser females engaging with the app, and English than Hindi. Again, we know some of these inclusion issues. So this was published in 2022. I'll skip this. So I'll end that by saying that basically, when we look at AI and social good, it's a very complex space. Okay, we can develop models as data scientists, but will that models be used? Will those models be used? Is a completely different ballgame. You need to work very closely um, with implementers. Those implementers may be clinicians, maybe governments, maybe some NGO, right, and so on. But then also there's a lot of challenges that may come up during this. So I think it's beyond just having, and that's what I started out with, right? Data gap, knowledge gap, insight, policy, right? What makes to the top is very little. What has made started making in our work, I think AMR Orbit and AMR Sense are two things that at least has uh, ICMRs, collaborations, and hospitals. We are starting to see some dent, but we'll see if that becomes a policy. It's very early days for AI to become a thing that we can actually treat as a policy. So we need to integrate nuanced context. We need to be explainable, especially for policymaker. We can't give a blind prediction. They won't trust it, right? And it'll have to be explainable, validated, they can understand. Connected domain understanding, not just represent knowledge, but generate new knowledge and then build early feedback and some real world problems that are really staring at us need to be solved. So I think those are things that I would like to mention and stop with. This is my PhD students, and there's many more who do bachelor's thesis, master's thesis, and so on. But and our funders and supporters, most recently Trinity Challenge and I'll take a pause there and see if there's any questions.
I have a couple of questions slash comments. So one, I like this, love this slide. I would say not like love this slide, because if you were not going to show this slide, I was about to ask this question that we have a room full of engineers and who people interested in AI machine learning who love their models. What advice would you give? But I think you already said that. So thank you for that. The other question I had, and you briefly mentioned this, that while AMR is one important topic, but you also mentioned that infection prevention is very important. So how do you envision AI usage, AI in, let's say, other kind of, let's say, sensing for that prevention, infection prevention?
I think this is exactly what we're doing in MR Sense. So Washkaro was an app that uh, originally, before COVID came in, was meant for preventing sepsis in the community. So we said that more mothers need to be aware of sepsis because we observe that babies get treated with sepsis, they get discharged, and they come back after 20 days, 10 days, month, because the infection control practices at home are not dealt with. So we can't solve a problem just so. Washkaro app was actually, we were able to quickly build this. This was presented in the WHO consult. We were able to roll this app in March of 2020, not because we already had a backend pipeline of things built for sepsis, which we then just had to tweak the literature and WHO and of that to whatever was available back then. And news stories were abundant to tune into COVID. So Washkaro started as WASH stands for water, sanitation, hygiene. So that's a key part. So we envision that going forward, I think AI can provide some of these sort of at least awareness raising, ease of awareness raising. It needs to be much more. Now it's at that time everybody was looking for information. Now the first question will come is let's validate this first, right? So and then so that's the change that has happened, which is good. But I think that's something we are doing with the AMR Sense, that we are building more awareness with those infection escape game, understanding what is the right information, debunking the myths and so on. So it has an important component. I would say it's a sensitive space because wherever there's information, there's also misinformation. So you need to have a partner. For example, there is an agency, getting the name, which is an international, I mean, it's basically, which just does that fact checking. I think something like fact checking something. So who can say, okay, you this is right or wrong. So it has to be human in the loop kind of thing, where you have human fact checking and then AI also, and then systems improve.
Okay, thank you. So I'd like to thank you on behalf of all of the students. So I would be very honest in saying this is perhaps after a long time I'm hearing a talk where none of the students and I was like fully engaged. I didn't see anyone checking their phones except for maybe 1-2 minutes. So we can grant that. So thank you, very engaging session. And I'll ask the students in case they have some questions, we can like send them or they can directly write to you. I don't think we have any questions. So thank you. Thank you, Tavpritesh. Wonderful talk.
Thank you, Nipun, for giving me this opportunity. Thank you, students, for being patient and for your engaging questions. Thank you so much.
Thank you.